So yeah, I'm just thinking about getting some filler, right? Just to
Oh,
get
like
ready.
just
Oh wait, hold on,
right.
we're live. We're
What about?
live.
Oh, are you live? Oh,
Just
oh wait.
kidding. All natural.
She said I'm on that crowd. What you know about?
Hi everyone. Thank you so much for joining my very first inaugural Virgin Live. So glad you could be here today. I'm so excited to be doing this. This has been a long time coming, and I finally got the cojones to get together and do it. And to hold my hand and do it with me is my very special guest and friend, and many other things, Mr. Dr. James Simmons.
Why,
James, how are
hello.
you?
I am doing very well. I am so glad that I am your first. Like I'm the
I know.
first of the
First
I'm
of
your first
many.
first of so many. And I love live. I love live so much because you never know. Like, look at all these people coming in, like Bjork and Jamare and Wade and whatever. Like, I love it. I love interacting with people, and I love being challenged with questions. And just, I really am actually super honored that you asked me to do this. I'm glad to be here.
Yeah, same. I love doing my videos, my edited, polished videos, but the best part is being able to engage and interact with the audience. So, hi everyone, if you're joining, this is going to be an engaging session. We want your questions, we want your comments. Please feel free. We'll get to as many questions as we can throughout, but we're here to talk about HIV, and we're here to talk about the experience of living with HIV and pry into some of the concerns and questions that y'all have.
Ta-da! Because
Whoop, whoop.
people have lots of questions, right? Like people, I
Yeah,
think this,
rightly
by the way,
so.
we're live. I never get to do this because I'm not live either. Where all are we live? Right. We're on my YouTube, LinkedIn, and Twitter, I think, for the first time ever.
Yeah, tell us where you're all hailing us from. I'm in Los Angeles.
You're in Los Angeles. Yeah, we want to see everyone. And we're on what of your channels, right? Are we on your Instagram? I mean
We're
on
on
your
YouTube, Facebook, LinkedIn, Twitch, and Twitter.
wow. Wow. Okay. Super fantastic. That is awesome. Hello.
Where are you? Where are you based? I don't even
Me,
know.
I'm in LA. Yeah.
Oh, okay. Yeah, that's what I thought.
Yeah. Los Angeles. Alabama, Richmond, Virginia. Yeah, boy.
Hi, Olan.
And the Bama. This is fantastic. So, I mean, while we got some LA folks here, I'm glad everybody's shouting out. So, just a little like context, I guess, as we go in. So, I am a hospitalist nurse practitioner. So primarily what I do is work with like critical care patients in the hospital, but I am also a clinical ambassador for the CDC's Let's Stop HIV Together programs and have been for 3 years. And I do a lot of advocacy and activism work here in Los Angeles, Southern California, around the world, and whatever, around very much HIV prevention, like PrEP. That's what my doctoral research was in, but then also like U equals U. So I'm running around, standing on the soapbox of U equals U. So a little bit of HIV primary care sometimes. So if you folks, Saint lunatics in the house, have like HIV primary care, very, very specific questions. Some of those I can answer. Some of those I will get back to you, which I'm actually really good about. The other thing too, just because, I have to say it, y'all can ask me anything you want. Honestly, everything. Raif, did I tell you about this speaking engagement I did on Friday?
No, you did not.
Oh my God, I got some of the best questions I have ever gotten at a live speaking engagement. We talked about HIV, we talked about gonorrhea, we talked about whatever, but I mean, how crass can we be? I mean, we're on LinkedIn, so I gotta
Yes, we are on LinkedIn. The LinkedIn folk are a little more buttoned up, but some F bombs here and there are okay in my book.
Well, I mean, let's just say there were some really, really intense, juicy sexual questions about like things being inserted with drugs and other things inside of people and like what happens and whatever. Like, that's great. And I just want y'all to know, like tuning in, like that is my jam. So please do not be afraid that you want to talk about, and we will talk about it. if I don't know, I will tell you I don't know. We will look it up and we will find the answer for you, because this may be, ready, drum roll, the first of a series of lives that Raif Derrazi and I are doing together.
For
How about that?
sure. Yeah, I would love to do that. So let me ask you a top of the line, high level, bird's eye view question to start.
Sure.
What is your current assessment of the global HIV epidemic?
Hmm. Such like a, you're so serious. You had your like your reporter question voice on there, right? If you were like, Dr. Simmons, tell us your current assessment of the
Yeah,
global HIV.
it's a question that I'm going to be routinely asking everybody that I interview, so that I can get like a broad spectrum idea of everyone's perspective.
Yeah. I think it is, I think we do have to sort of separate what happens in countries with great healthcare access predominantly to preventative care and then treatment. So places like Canada, most of Western Europe, um, Japan, United States, etc. Some countries in South America, it's fairly easy. Asterisks. I know not for everyone, but it's fairly easy to get your hands on treatment and fairly easy to get your hands on PrEP. And so this whole we're going to end HIV by 2030 with U equals U, and with treatment as prevention and PrEP as prevention. It's an ostentatious goal, but possible in those parts of the world, I think. I think we will be having a very fundamentally different conversation about HIV 5 to 10 years from now. Kind of like we are now having a fundamentally different conversation about HIV than what we had 5 to 10 years ago. That being said, if racism and capitalism and imperialism and colonialism and all of those other isms have left many places, like a lot of countries in Africa, a lot of countries in Southeast Asia, behind when it comes to HIV care in particular, and then prevention. So PrEP is much more readily available than it used to be, even in the last kind of the tail end of the pandemic, and some of these particularly African countries and then Southeast Asian countries. So that's helping a lot. But we are still unfortunately seeing really high rates of transmission that are probably unnecessary, and really high rates of opportunistic infections and illness and things like that in places that don't have access to the resources. So my general push is, sometimes people really ask me like, why are we doing so much? Why are you so much about HIV all the time and talking about HIV and AIDS? And a lot of it is because I feel like
Why are you so obsessed?
why are you so obsessed with HIV? I feel like we are at this, I don't know if there's sports people here or whatever, but like we're starting the fourth quarter. We are at the 20-yard line marching towards our end zone, right? I used to run track, like it's the last 50 meters, like all of these things where it's really, really hard, right? Mile 18 to 20 of a marathon for people who've done marathons. Like we're in the really, really hard part. It's sticky, it's weird, it's gross, it's not getting a ton of headlines, but we're so close to what could be like solutions and really drastically cutting the numbers. And so now is the time we got to push even harder, I think.
Hmm. So from what I gather, what you're saying, excuse me if I'm putting words in your mouth, but it seems like you feel that in 2030, with this initiative, we could potentially, realistically, end the epidemic, but that it would be limited geographically because of differences in availability of healthcare, basically, in different countries.
Yeah, I think that's the
Is that
easiest
a
way to.
privilege thing?
Totally a privilege thing. Totally primarily capitalistic healthcare environment things. Primarily, this is really, I don't know if there's any drug companies on watching, whatever, but like the really difficult push-pull relationship we have with the Gileads of the world, who are fantastic and amazing and do all these wonderful things and spend a lot of money and created these medications and are absolutely changing people's lives. And like some of the sole reasons, them and the research are some of the sole reasons why people are like living forever with HIV. Everyone runs around, it's not a death sentence anymore, all that. That's great. Also, like they are beholden to their shareholders. And that requires them to turn massive profits. And so it is not profitable to just like give entire subcontinent of of sub-Saharan Africa, a tripla. Like it just is not, that's not profitable. So I mean, if you really, I know I just like went right there, but if you really want to get into it, yeah, that's part of it. We like to couch it. We like to sort of respectability politics it in access and all of these things. But when it comes down to it, like healthcare, I'm in healthcare, right? Healthcare is a business, and people have to make money with the business. And unless it was like a super nationalized sort of thing or globalized healthcare, like,
Well, and that's something that I hear. Maybe I don't really hear like people living in different areas of the world saying we don't have any medication here available, but I will hear, oh, we don't have the latest and greatest drug that that I'm maybe talking about on YouTube or something like that. We have this generic, and we have something that's similar, but is it on the same level as the new drugs? We don't know, but this is all that our government can or is willing to pay for or bring into the country. So
mhm, mhm. That just so the kind of the people watching know, there's generally with medications, there's a 7-year patent. Generally speaking, it's 7 years. Sometimes the patent can be extended, it can be appealed. There can be all different kinds of things that can go on with patents, but more or less, you have a patent for 7 years, and once that 7 years, it's called the cliff. Once that patent for a drug goes off the cliff after 7 years, it means that other drug companies can start replicating that medication and then charging whatever they want for it. So that's generally when we find generics. So part of the reason that a lot of places are not up to date on medications, or they're about 7 or 8 years behind, is because after 7 years, the drug companies have, I'm really oversimplifying, but after 7 years or so, the drug companies have essentially made what they're going to make on this medication by charging what they can charge. Everyone else can now make it cheap. So people go off and make generics. So then it is cost effective for them to offer it to everybody at that point.
yeah, yep. Okay, so we do have a couple questions.
Yeah.
So let me put the first one up on the screen here.
I love how I'm glad that you have to drive. I'm not a good driver in the
Meets.
middle of a
This is
live.
this is a lot. It's a lot,
Okay.
but I'm muddling through. Okay, Borg has a question. Can a co-infection with hepatitis A block the detection of HIV from fourth generation tests and also RNA PCR test over 2-year needle assault? I don't know what a quarter of that means, but I hope you do.
I don't know what test over 2-year needle assault. So maybe the potential, the first injury or the first exposure was with a needle 2 years prior. Am I interpreting that the correct way?
Let us know in the chat. I'm watching.
Yeah, we're looking. Okay, so I'll repeat it. Can a co-infection with hepatitis A block the detection of HIV from fourth generation tests? No. Very, very separate. We do see a fair amount of co-infection of the hepatitis and newly diagnosed HIV. Yes, often in populations of people who use needles for recreational drugs or otherwise. Yes, from 2 years ago. So no, we're testing for something fundamentally different. But I understand why you might have this question, because we often will see both together. So we will see a new hepatitis, particularly A or B hepatitis infection and HIV. Often we will see it with other STIs, sometimes with syphilis. And then a lot of time, especially in populations of people who use needles for recreational drugs or otherwise, sometimes we'll also see other things, a sepsis, a MRSA from the needle that is causing a pneumonia or some sort of skin infection, right? Like we'll see these kind of opportunistic ones pop up, but having a brand new diagnosis of hepatitis A and a brand new diagnosis of HIV together, it won't block the test. We can detect both.
Great. On that same vein, that's often a concern that I hear from people is there a habit? Is there an action? Is there something that I might be consuming in my nutrition, in my diet? Is there anything I'm doing that could lead to a false negative HIV test? Is in general, is that an issue? And if is are there certain things that people should be cognizant of or aware of that might?
Mm. So there are. So the easiest answer for this is no. In terms of the things you're consuming over the counter or supplements, things like that, are they going to give you a necessarily a false negative? However, you can ask for the most recent generation of test. You can also ask for, people are really familiar with like antibodies versus antigen
Thanks to
now
COVID.
because of COVID. Right. So you can ask whoever's giving you the test, is this testing for like a P24 antigen and HIV antibodies? Is this a rapid test? Are you confirming with the PCR? You can ask all of those questions if it's something that you're worried about. So, but generally speaking, even the like third generation antibody tests are really good. Again, there's a window, right? So depending on which test you're looking at, those generation tests generally couldn't, 2 weeks was rare that we would be able to detect, but we're more looking at like 4 to 6 weeks after exposure. Now, if you're looking at tests that are looking at antibodies, antigens, it's a PCR confirmation test, that window of exposure can be smaller, but a lot of times people will say, oh gosh, I think I had an exposure in the last 5 days. Let me get my HIV test. Okay, it's negative. Phew.
Get on PEP regardless. Get on that PEP.
Get on that PEP regardless. And we're going to need you to come back and test in a little while. At least a couple of weeks, probably more like 6 weeks to confirm. So it's a legitimate question for sure. And you can just ask, right? I do not know, in all the years I've been doing this, I do not know one person who is helping folks test for HIV who is ever going to be mad at you for being like, which test is this again? Is this like the PCR or the other one? Right. You don't have to know the names of the tests. Just ask them like, girl, which test is this? Can you do the one that's the PCR and the antigen? Like, can you give me both? Because I'm like super worried. Just ask. They'll be like, oh yeah, sure. It's the same blood or the same mouth swab or whatever. Right. So don't hesitate to ask.
In most places anyway. Some places I know that it's a difficult request. Okay. I got some more here. Let's see. Next up, put it on the screen.
If that is a difficult request, by the way, I want you to go to cdc.gov/HIV and have a test mailed to you or do their test locator.
I'm just thinking of people in other parts of the world.
Yes, that's true. I forget Raif, you have such a global audience. Yes, I am quite US centric at this point.
Okay. Medicine, there are many of them, but we need more doctors to have knowledge to treat patients with HIV conditions. We need more doctors.
Ain't that right, sister?
True that.
Not to put a gender on you. I'm just calling everybody sister these days. We sure do. And I think one of the biggest issues is that there are so many primary care providers, either in the hospital or in the clinic setting, who just have zero HIV education. And that's actually part of what, not that I'm here to super carry the flag for the CDC all the time, but that is part of what the CDC is trying to do with their clinical ambassador program, of which I'm a part of, is have clinicians like me try to help educate other clinicians about just ask the damn question. Like, hey, are you sexually active? Do you use needles in your drug use? When was the last time you had an HIV test? Okay, let's just check for HIV. Are you on PrEP? Nope. Let's talk about it, see if it's right for you, right? And if you're Dr. Dimitriakis in New York really did this the best starting, it was 8-10 years ago almost at this point. There's status neutral care. So if you've not heard that, status neutral means we talk to everyone about HIV, just like we're going to talk to everyone about blood pressure, the mole on your feet, right?
Mhm.
Everyone that we always have a conversation with folks about everything. We're also having a conversation with you about HIV, regardless of your status. If you're HIV positive, we get you into care and we have a conversation about it. We start you on meds, we do other tests, we keep it pushing. If you're HIV negative, great. We talk about PrEP. We see if it's right for you. If it is, we get you on PrEP. If you don't want to do PrEP, we talk about your other options. We keep it pushing. But everybody gets an HIV conversation. And so I think you're right. Even outside of getting more HIV prevention and care specialists, it's about educating the folks who are already in place to do just a little bit better job at their HIV care.
Yeah, because especially with HIV, it's not just having a conversation about HIV. There's a whole continuum to care, and there's a way that you have to address patients or humans living with HIV recently diagnosed or just going in for testing that's different than a lot of other things because of stigma, because of so much surrounding the virus. Knowing how to talk to people about it
Mm-hmm.
without
Mm-hmm.
making them feel judged or criticized, looked down upon. It's so easy for healthcare professionals to do that
Yep.
because of a bias, because they're not trained otherwise.
Mm-hmm. Very, very much so. And unfortunately, that bias. I mean, we've learned so much about the biases in healthcare related to gender, even the biases that like cisgender women face, just starting there. And then going on through all of us folks of color and all of us queer folks and all gender fluid folks and sexually fluid folks and all that stuff, right? All of those biases. And then you add other sort of disease processes on that. And this is no shade to physicians, medical doctors, but a lot of the compassion of talking to people like a human being isn't taught as well in medical school as it is in nursing school. So
Mm,
sometimes you will get people like me who are nurse practitioners, primary care providers, we have a doctorate or not, but sometimes people just like having conversations with us a little bit better just because
yeah.
our core is as a nurse and our core is the whole person. Now, this is not all physicians, of course. I'm not speaking, and not all nurse practitioners either. Some nurse practitioners aren't great. But like in general, a lot of people are like, hey, I love my nurse practitioner because I feel like I can talk to them like a human being and not feel as judged.
Yeah. And to make a good example of a doctor who handled it very well, I still remember to this day, early on when I was diagnosed, I met with the doctor, and at some point he consciously removed his glove and touched my hand and spoke to me,
Oh.
and that was very like it meant I was like wow, like it was shocking in a way. It seems like such a small gesture, but it was like in that moment I knew he's not afraid of me or
Hmm.
afraid of getting HIV from me. So things like that.
Did you Were you ever able to share with them how powerful that moment was for you?
No, and I don't even remember what doctor it was.
That's all right. Right? They say, right? You don't have to remember their name or whatever, but you will always remember how they made you feel.
Yeah, it wasn't like a primary care. I forget what situation it was, but
I I'm so glad that you shared that, and I hope that many others get the opportunity to have that type of connection with their healthcare provider.
and my
Because
most recent. Sorry, go ahead.
no, I was just going to say most people's experience with their healthcare providers is shitty. It's horrible.
Yeah, I was just going to juxtapose that with a recent because I had to find a new doctor, and I'm not going to this doctor specifically. And a huge part of the reason for that is when I went in my first visit, um, he kept his distance from me the whole time, and then at the very end he did the elbow, and
What?
this is like post lockdowns, post COVID's everywhere, and I'm like, bro, like how hard is it for you to just shake, like I just met you, you can shake my hand and you can literally walk out of this room and you can sanitize and go about your day, like
That
yeah,
elbow?
just
Even a fist bump. Right, right. Hey, this is how we're gonna sign off when we leave. Okay.
good chat,
Thank
good connecting with all of you guys.
Right. Thanks. Glad everyone. Yeah. Glad we hope you had a human connection here. Listen, even a fist bump's better, right? Even a fist bump is like a little bit
Yeah.
more personable than like Freaking elbow. Are you kidding me? I'm sorry, Raif. I'm sorry that happened to you. And please let me use this opportunity for everybody watching. If you don't like your healthcare provider, whatever they are providing with you, if you are in a place, not the elbow, if you are in a place where you can change, like if you have the privilege of that, switch it up on them. There are plenty of us.
Yes.
I love what I do and I think I'm great, but my sense of humor and my approach is not always appreciated by everyone, right? Sometimes people they want the boring, whatever, very medical, very stodgy, whatever. Like this is how I am with my patients, by the way. And most of my patients really appreciate it, but sometimes they want someone to come in and just like read the textbook to them. Cool. I'm probably not your dude. So fire me and find somebody else. I promise you there's somebody else who would love to take care of you.
I
So
love being an advocate, but you got to be your own advocate too on some level. You don't need to go on YouTubes, and you don't need to go on the socials and the interwebs and spread your everything to the world like I do. But when it comes to key things like getting a good doctor that you can connect with and feel vulnerable with and feel safe with, you got to speak up for yourself.
yes.
Okay,
Absolutely.
we have a question. Oh, does it not show the whole thing? Oh, it doesn't. That's weird. Why would it do that? I can see it on the side. Can you see it there?
Do practitioners at any poo?
Hi, guys. I work with geriatrics who could have been exposed to HIV at any time in their lives as they get older. And I love talking about HIV and aging, by the way. They
Mhm.
may show symptoms of opportunistic infections due to weakened immune systems and other chronic conditions. Do practitioners at any point or at what point would they recommend testing? Do they feel it's worth looking into?
Yes, always. Oh my gosh. Um, I, I, I think so many of us, Aisha Rogers, thank you for that fantastic question. And um, on this little restream, Raif and I are learning. You're coming through at us through LinkedIn. I don't see your credentials there. So if you are Dr. Rogers, my apologies. But thank you for the fantastic question. So
Can you
I think,
before you go into it, can you rephrase that as if I'm a 5-year-old, just so that I can understand and so some other people can understand what is being asked?
yeah, I mean, bottom line is how quickly do we jump to HIV testing? So in someone who is older and they have an infection, that might be what we think of as an opportunistic infection when someone has HIV or it has progressed to AIDS, right? So their T cells are super low, less than 250, all of that stuff.
She's an LPN. I don't know what that is.
LPN, excellent. A licensed practical nurse. Very good. Thank you, Aisha. So what we generally do is, I think a lot of times when we were in school, when we were younger, it was like this big deal, right? A lot of states required you had to consent for an HIV test, and then they would put you in a registry. And there was like a really big deal around testing, even in the hospitals. And so it was like this whole big consentable process, like, whoa, big hairy elephant in the room to get an HIV test for someone. And it was like a big deal. Now it is much less of a deal. And partially because of that, we go to HIV testing really fairly early. Now, that being said, in geriatric, and I work a lot with geriatrics, so in elderly populations, lots of infections happen because there's lots of weakening of the immune system for a multitude of reasons. Not just age, but generally speaking, older people have, we call them comorbidities, lots of healthcare stuff going on that could weaken their immune system. Opportunistic infections are somewhat specific. So like there's a specific type of pneumonia, there's specific type of fungal infections, there's specific types of things that we see that wouldn't normally happen in someone, even if they're a little bit older and even if their immune system is a little bit weak. But then if we see like a pneumocystis, a PJP pneumonia, wow, that's really rare. We usually only see that with people who have advanced HIV or AIDS. Oh, we better check for that, right? So I think HIV tests, Aisha, to your question, probably happen a lot more frequently than you might realize in people who have what kind of, I hate this word, but we kind of look like weird infections. Like, oh, this person's got kind of a weird infection. We're not sure what's going on. Something's causing their immune system to not work super great. Maybe it's
Mhm.
HIV. We should test for it.
That kind of reminds me of when I went into the doctor initially, and I was in a relationship. For 3.5 years at that point. Duke, are you whining?
Oh,
It's
I
like
can't hear him though. Do you have pictures? Can we see?
dog
Can you see?
whining at the door.
No.
I'll try to pull something up. But when I ended up going to the hospital, and it was just like a blanket. I don't know what's going on with me. My throat's hurting like crazy. I thought that I had strep. I took antibiotics. It went away for 2 weeks, and then it was back. And so I was
Mm,
like, I gotta see somebody. And that was that. They would look, and they're like, immediately they thought like maybe I have like an STD or something like in my throat from throat STDs. The way that happens,
right.
and and then and then they went from there and just immediately gave me a whole array of tests. We're just going to test everything, and HIV was in there, and that's how they
Yep.
found it.
Wow. A very
So
a fairly common story, right? A fairly common. Oh my gosh!
there's
Stop
my
it!
little Dookie,
Hello, little Papa.
my little boy,
What's his
spoiled
name? Duke, you said?
Duke. Yeah.
Hi, Duke. Oh my God, so cute. Um, yeah, a lot of times there's the, we call it like antibiotic failure or treatment failure. So someone was on something, we gave them an antibiotic, they got a little better, and then as soon as the antibiotic finished, they got worse.
Hmm.
Sometimes that makes us go, huh, why did this antibiotic not work? Now, normally it was the wrong antibiotic for the wrong infection, or we didn't give it long enough, or
Right.
the patient didn't finish their
Didn't
antibiotic
take it properly.
properly, didn't take all of it. But sometimes when someone who is maybe otherwise young and healthy, or it's one of these sort of weirder looking opportunistic infections, we're like, huh, we better check, like your providers did for you, right? Like, let's throw the kitchen sink. Let's just like test for
Yeah.
everything. And HIV is usually included in that.
Yeah. Great. Okay, I have another question here. I'm going to pull up.
Mm-hmm.
What's the best way to get involved in HIV? I did research in undergrad, but I'm wanting to do more to gain more experience. What a lovely question. I really, as someone living with HIV, I really appreciate whenever I hear things like that.
Yeah. Well, I mean, Raif, what do you think from your standpoint with all of the, I mean, we both are so active in the community, but kind of a little bit in different ways. What would you say to someone to your answer to this question?
I would say to start local and
Hmm.
go for your local LGBTQ center, HIV organizations that are local. There's usually local organizations, and there might be like a national organization that has a local branch, if you will. That would be my. And you can use that. What's that? You should know this. I'm gonna put you on the spot. What
Oh,
is that?
I got Google. I got my
What's
keyboard ready.
that .gov resource locator website where you can go? You literally just put in wherever you are in the U.S. and it will tell you all the pharmacies, all the testing centers, everything in your area.
CDC.gov/HIV. That's how they go. I'm gonna do a commercial. CDC.gov/HIV. Or you can always Google HIV testing locator, if you're looking for it, or CDC HIV testing locator. I 100% agree with you, right? If that was going to be my first response, go local, meaning pull up the you Googles and HIV organizations near me, right? And see what help they need. In terms of, in most sort of philanthropic endeavors, so whether it's breast cancer or March is Colorectal Cancer Awareness Month, probably need to post that video tomorrow before the end of the month, right? Colorectal cancer awareness, all these things. The bigger the organization, usually the more corporate dollars they have and the more resources they have. So these big national ones, they need help too, but they usually have a lot more resources. And then as the organizations get more local and a little bit smaller, they usually need more help. A lot of these organizations at a local grassroots level do that really heartwarming, yummy, amazing, wonderful work that like you think that you're doing, right? Like you're sitting down and you're having a conversation, kind of like my speaking engagement on Friday. I think the organizers were hoping for a larger turnout, but there were maybe about 25 people there. And I thought that those 25 people were so engaged. Like it was the best conversation. We were super engaged.
Yeah.
Everyone was like very there. There were tons of questions. We ran out of time. Like it was fantastic. I would much rather have 400 conversations with 25 people who are really engaged and want to be there and learning, and I'm learning from them and all of that, then feel like I have to do everything on such a grand scale. So that's why I say like your local organizations probably really need your help. They probably already have ideas as to where they can plug you in.
Exactly.
So if your undergrad was in like graphic design, they're like, okay, design this flyer for us really quick. And then, oh, by the way, you're going to come volunteer at this event for the flyer that you just designed.
In our chunky Angel Fire website from 1992. You remember those?
Not
With
Angel
the little
Fire.
Not Angel Fire. There's nothing angelic or fire about it.
No. She said it is not fire whatsoever. That being said, if there is an organization that really speaks to you, I promise you they are never above an email or a phone call or a DM from wanting to get involved. So like,
Exactly.
Color of Change, I think they're not an HIV specific organization. They do more grassroots root around white supremacy and anti-Blackness. But Color of Change is an organization that has a big footprint, but does some really, really dope local stuff. And I know that they have had it's like celebrity involvement from celebrities who just literally DM'd them. And they were like, yep, come on in. Same things with people who are non-celebrities. So yeah, just dip in for sure.
Oh, hey, I want to call out Xandra is my alter ego, Patricia. Patricia is a good friend of mine. She's someone that I work with through the Hope Collaboratory. It's funded by the NIH, and we work in conjunction with scientists and researchers who are working towards an HIV cure. And they're actively working to bridge community with science and research. She is our community engagement coordinator. So, Patricia, thank you for joining. She has a question for us. So, let me put that up. If you could change one thing in the ways research clinical trials are run, what would it be? Good question. I don't necessarily have something for the way they're run because I'm not really familiar with clinical trials, to be honest. But I do know that it is a challenge and it is a difficulty ongoing in finding and having proper representation and diversity in clinical trials. And so onboarding those people to not just finding them, but to establish trust with community. I think that's a huge hurdle. And we saw that with the pandemic too, the amount of distrust of healthcare and anything related to the government.
Rooted in reason, rooted in fact, right? Rooted in
real shit.
Real shit. Rooted in you have every reason to distrust the government and big pharma and science, big science,
right.
And all of that.
Yeah.
That's part of the reason I sort of hesitated with this. I wasn't hesitating. I was more trying to give a really thoughtful answer. So same thing. I'm not running around like doing tons of clinical trials or anything. But my familiarity with them is a little bit better than the average bear. So that being said, same thing, Raif. I think we're moving in the right direction with this, but it sort of sometimes feels like let's design a research study. Let's answer a question. Let's have a hypothesis. Let's answer a question. And then it's by the way, we should probably include some diverse folks in this so that we can make our numbers more generalizable, right? To a mass population, rather than what I think, UCLA, I have to tout them a little bit because that's where I got my doctorate, full disclosure. But
that's where I went to school.
Right. Sorry. Oh, there we go. See, we're both Bruins. So I think what the HIV research work that UCLA has led has been very queer and Black focused from the beginning. And they've sort of required, when they're partnering with drug companies and others who are funding some of this research, that those initiatives they've started from the right place. They've started from the place of, in the United States, primary, incidences of HIV are among 18 to 35-year-old Black men who have sex with men in the southeast part of the United States. So we're starting from there and building our trials around what the community needs by involving the community. But that feels so novel and so fresh and so like awesome. And it shouldn't be, right? It should sort of be the other way around, rather than like we're taking this novel approach. And so I think there are institutions like UCLA. I think Hopkins is getting a little bit better about that. I think some of the other big HIV researchers, even UAB, are starting to get a little bit better about not being an afterthought about including the right populations, and actually having their clinical trial designs being driven by the data, and the data telling us where the populations need the research in, if that makes sense.
Exactly. Yeah. Logical.
How dare we be logical?
Yeah. Well, great. We are over our 30-minute that we wanted to do.
How did we do, everybody, on our first live? This was fun.
Let us know what you thought. We want to keep doing these, and I'm open to one more question if anybody has the last burning question. Otherwise, we'll wrap it up for today. Yeah, I think this was really good. We touched on a lot. We touched on a lot of topics, and it just happened organically. And thank you, everyone, for all the amazing questions. This will live on my. I don't think LinkedIn stores it or anywhere else, but for sure on YouTube, it'll be up there. And you connected your YouTube as well, right?
I did. My YouTube, LinkedIn, and Twitter. I've never gone live on
Speaking
any
of, where can people go if they want to follow you and or your work?
Oh, thank you. I am everywhere on all social platforms at Ask the NP, one word, and Ask the NP. On TikTok, it's Ask the NP _.
Oh, wait, I just realized I can chat in the Ask the at. Did you say there's an underscore on TikTok?
Just on TikTok at the end, but everywhere it's Ask the NP. Wait, and I don't know how do I chat on the big board too? Can I? Or is it just you as the as the host chat there, but I can't.
Oh, but Facebook and LinkedIn, I can't for some reason. Okay, I gotta figure that out. Anyway, that's that. So follow Dr. James Simmons. He has a lot of great content. He's always putting out informative videos that I love watching, that are cute and funny and educational, which is, that's the holy trinity of
cute, fun, and educational. That's going to be like my new tagline. I'm the holy.
And if you're watching this after the live, put those comments down on YouTube in the comments below. I'll keep it for next time, and we'll be back here. Do you want to do this again next week, next Thursday?
Yeah. Let me make sure. I'm
putting you on the spot. We'll find the time.
It looks like I can. Let's do it.
Okay, great. I'll put it in my thing as well. All right. Thanks, everyone. Thank you for joining, and we'll see you soon. Ciao.